Thank you. Hmm. Thank you for the introduction. It's a real honor to be here today to talk about a topic that I'm very passionate about, which is blood management and obstetrics. I think there's no greater honor than to be able to take care of women during childbirth, which I think is one of the greatest things that a person can do is to have children. At any rate, I am the former chief of the Department of Anesthesiology at Magee Women's Hospital. I'm currently kind of winding down my career as I head towards retirement. Um, McGee, just to give you some sense of the size and scope of the hospital, is a hospital that does 11,000 deliveries annually, which ranks in the top 10 of maternity hospitals in the United States. I know for much of the world, it's kind of chump change to do 11,000 deliveries. Many hospitals in India and China do 30,000. Um, but at any rate, it's plenty of business to keep us occupied, and hemorrhage management tends to be one of the things that we are facing with increasing frequency. So if I can get my slides to move. The historical perspective of medicine is something that I find very fascinating. Um, and obstetrical hemorrhage is kind of the beginnings of transfusion medicine, um, which started back in 1818, where Dr. James Blundell published this piece of or observation in the journal Lancet, where he observed a woman bleeding to death. Um, and came to the conclusion that there needed to be something that could be done for these women when they were bleeding. And so he designed this particular device, the Blundell's blood gravitator, to facilitate transfusion. And typically, the transfusion was initiated by the father of the baby, where a nick in the radial artery was made and the blood would pour into this gravitator. And it's important to recognize in this era, there was no anticoagulation of the blood. So the movement of the blood directly into the maternal circulation needed to be fast, otherwise, coagulation would be a problem. In addition, there was no recognition of the ABO typing of blood. So, in Blundell's first 10 reports, five of the women did survive, which is pretty miraculous given that there was no understanding of ABO typing and ABO mismatching. But anyway, this is kind of the heart of transfusion therapy. And it was performed in this way for about 100 years until the advent of the modern blood banking system, initiation of anticoagulation and recognition of ABO matching. And I think there's probably still some room for this kind of transfusion, especially in a country like Nigeria that has a fairly significant maternal mortality. So in the United States, this is a continuing problem. This is the rates of change of maternal mortality in the United States over the last 20 years. And you can see that this particular graph ends in 2014. And this was the start of a public outcry about maternal mortality in the United States. Um, and subsequently, to the recognition that this was a problem, there's been a marked decrease or marked change in the maternal mortalities, as is evidenced in this graph from the Center for Disease Control in the United States. And we've done a lot of things to try to address this, and I'll talk about some of these initiatives later. One of the interesting pieces of data that comes out of the CDC is that the disparity in maternal mortality between different racial groups, and it's interesting to look at Black Americans tend to have maternal mortality rates that are threefold greater than that of whites. Um, and this has been attributed to socioeconomic differences. But what's interesting is that the Hispanic population is very similar, um, which makes me question, what is going on in this particular patient population. And I'm curious to hear your thoughts because the maternal mortality around the world is considerably different depending upon where you are. This is a map that was taken from the WHO, um, the World Health Organization, where it shows that Nigeria has one of the highest maternal mortality rates in the world. And I saw data that suggested that the rates were somewhere between 1,000 and 3,000 deaths per 100,000 live births, which makes it about 100-fold greater than the United States. So there should be, I think, a major public outcry in Nigeria about this particular problem. Um, but it's curious. But anyway, the number of maternal deaths in Nigeria is about 20% of all maternal deaths worldwide, which makes it a crisis in my mind. In the United States, the causes of pregnancy-related death are shown here, where hemorrhage is number four, secondary to a number of different other problems. But I think what's interesting is if you take hemorrhage plus thrombotic pulmonary embolism, which is kind of too much coagulation, and compare it to too little coagulation, the problem associated with coagulation dysfunction makes it the number one problem with or associated with pregnancy-related death. So I've focused a lot of my work on trying to understand coagulation function in pregnancy and into the postpartum period. So where can we start to address this particular problem? I think the easiest place is to look at anemia. We did some work in our hospital where it was found that anemia in our pregnant women increased the risk of transfusion eightfold. In other words, women that presented with anemia um, for their delivery were 8 times more likely to be transfused. And at least with this meta-analysis, was found that about 70% of women um, around the world were presenting with anemia on presentation. And this is something that's super easy to address. And would strongly encourage that this be the starting point for any attempts to try to resolve maternal mortality. During pregnancy, there's a marked increase in blood volume, as is exhibited in this particular graph, where over the weeks of gestation, you see that the blood volume increases, though the red cell mass doesn't increase quite as rapidly. And I think part of this change in red cell mass could be ameliorated or improved through the provision of pretty aggressive iron supplementation. And if you look at some of the markers of iron storage, serum ferritin is the best marker, where you see that the ferritin levels drop precipitously during the course of gestation, um, to the point where at the third trimester they're considered severely iron deficient. And this is an average. And 20 is generally where we define, being the point where iron deficiency is identified, at least in our general population. So this makes it a really easy place to address in terms of building up that red cell mass, um, which in turn protects the woman from any hemorrhage that occurs. And the cost of supplementing iron is super cheap. It's about 2 cents per 65 milligrams. And the thing about iron is it's somewhat toxic. Many women don't want to take it because it's constipating, leads to gas. Um, so the recommendation from many hematologists is to give this every other day rather than every day because there is an absorption problem that occurs with giving it every day. So the every other day facilitates absorption and decreases the side effects from the administration. In the United States, we've started a more aggressive use of intravenous iron, and these are some of the drugs that we have available to us. And you can see Fairlesset or Vinifer is a relatively low-cost drug for an intravenous dose of somewhere between 125 and 200 milligrams. Um, and I think we should be more aggressive than what we currently are with this particular drug. So that's the number one item I think that should be addressed in taking care of or identifying or managing maternal hemorrhage and maternal mortality. Now, there's a model that tries to explain maternal mortality, and I think what little I know about Nigeria is this model kind of highlights some of the problems that you're facing in Nigeria, in that frequently there's a delay in recognizing that there's a problem. It's very difficult to differentiate when a woman is bleeding abnormally versus not. And getting that particular individual to seek medical care is oftentimes delayed. And then once they've achieved or reached a healthcare facility that has the ability to take care of them, oftentimes it's done too slowly, or they don't have the resources to take care of these women appropriately. And this particular model has been used by the California Maternal Quality Care Initiative, the CMQCC in California, and I think this organization has been responsible for some of that decrease in maternal mortality that we're seeing. And in this graph, what you see is causes of maternal death. And what you see here is the numbers of deaths related to obstetrical hemorrhage. And they've broken this into three categories, which I think is generally applicable to any hemorrhage, where they've identified a category of these women that bled to death, where there was a possibility of saving them. That's the blue portion of this bar, with the red being some chance and then the green being no chance. So this, of all the causes of maternal mortality, has the greatest opportunity to rescue these women from death. This is another piece of work from the California Maternal Quality Care Collaborative, where it shows the reasons for uh, death related to these various sources. And you can see maternal hemorrhage in the middle of the picture, obstetrical hemorrhage. There's a delay in response to the clinical warning signs um, of somebody actually bleeding more than normal. And this really is something that has become kind of ingrained in the United States care of women during delivery. And the way it's been ingrained is through a change in the way we identify hemorrhage during the course of a delivery. And we've started using something called a qualitative blood loss calculator, where we measure the weight of sponges that have been collected during the course of delivery. And there's a direct correlation of the weight to the volume of blood is represented here. So you can get a good idea of the amount of blood loss that's occurred by weighing sponges and measuring blood in collection reservoirs. And hopefully this can be a way of recognizing the problem. And we use kind of a hard and fast rule of 20 lap sponges is a kind of a trigger for us to implement larger degrees of care for these women. In other words, that acts as a target for us recognizing that there's something abnormal going on with a particular delivery. Now, I've done a lot of volunteer work around the world, and this is coming from a hospital in Honduras, um, in a town called Santa Rosa de Copan. And Honduras is the second poorest country in the Western Hemisphere. So I would think that this particular hospital is somewhat reflective of the hospital conditions in parts of Nigeria. And this is the labor and delivery suite. And the young woman in the right-hand corner is a woman that we brought to the United States to train in how to use auto transfusion or cell salvage equipment. But in this particular hospital, the women would labor two to a bed with their feet being in opposite directions in their beds. Um, but one of the problems in this hospital is the size and scope of the blood bank. And this is a picture of the blood bank. And these two units that this particular technician is working with are the only two units in this hospital. So if somebody has a major bleed during either surgery or a delivery, um, the amount of blood available to them is markedly poor. And I think this is a problem throughout much of the world where the access to transfusion medicine is limited. And I thought, as I was putting this slide set together, is that perhaps, this might be something that we could take home lessons from the American military. I was in the United States Navy for 14 years, and one of the things that we had to wear um, in duty was dog tags. And on the dog tags were a identification of what your blood type was, and we called this the walking blood bank, where people could be identified as being compatible with somebody that's been injured, and that particular individual could become an immediate donor in times of crisis. And I wonder if this is something that might be implemented in a third world environment where dog tags, maybe not for the whole population, but for selective portions of the population, might act as a walking blood bank for some of the rural areas where this might be life-saving in the same way that it was um, back in 1818 when Blundell first propagated the idea of transfusion, as is shown here. This is something that can be done relatively easily with relatively limited tools. So, again, reflecting on some historical perspective, this is an article again from the Lancet, dating back to 1874, where this physician, William Highmore, again in the observation of maternal hemorrhage, um, he basically stated that all the blood in the bed of the woman who was bleeding to death, perhaps it could be collected and warmed and filtered with gauze and re-injected into the woman. And this was the first mention of autotransfusion being used in medicine. And this particular technology or lack of technology was used for around 100 years until the advent of the modern blood bank, where anticoagulation and ABO typing were recognized. And there's about 3,000 case reports of people being saved with autotransfusion being propagated in this fashion. And I really wonder if this is an opportunity in this day and age to reinvent this kind of technology. And I'll speak about that a little bit more here in a few moments. And there's, like I said, about 3,000 cases in the literature about um, this unwashed, basically shed blood being collected and retransfused. This is a report of 272 cases in an ectopic pregnancy, um, where they identified old blood as being something that you didn't want to retransfuse, but it presented an opportunity to be life-saving in many of these circumstances. So this idea was evolved over a course of a century um, to this device, the Bentley autotransfusion system, where shed blood was collected in this reservoir and then just basically pumped right back into the patient without any processing other than a microaggregate filter. This device didn't last on the market very long because there was no stop mechanism on the pump that would pump this blood into the patient. And as a result, when the reservoir emptied, air would be pumped into the recipient. It led to a number of deaths that got the device taken off the market quite rapidly. But it again accentuates or highlights the importance of this unwashed salvaged blood being an opportunity to save people. And this has evolved into these modern devices. This is the device that we use in our operating room. It's a device from a company called Sorin. And this device washes and concentrates the red cells. Um, but I'm not sure that this is necessarily needed. At any rate, when these devices were first propagated or proposed to the FDA, the Food and Drug Administration in the United States, there was a big concern about the entrainment of amniotic fluid and whether or not that would lead to um, complications associated with re-administration. And I got to say, I wonder about the thought process that went into this, given that this technology was used for 100 years before the machines were actually developed. So what happened is that the devices were labeled as being contraindicated, and the reason they were labeled as being contraindicated was because nobody knew what amniotic fluid contamination would do. And the incidence is so low that it was very difficult to study. So the easiest thing to do is to just label the device as being contraindicated because of this amniotic fluid contamination. And this is the problem in terms of doing studies to prove safety is that the incidence, if you pool all the studies that are available, the incidence of amniotic fluid embolism is about 1 per 19,000 deliveries. So doing a study that would prove safety would require about 1.4 million patients, and that's never going to happen. What is there in terms of safety data is a collection of case reports or case series. This was some work that was compiled by Giancarlo Leombruno in Italy, where he compiled 1,665 cases of obstetrical hemorrhage with the re-administration of the autotransfused blood and found no problems with amniotic fluid embolism associated. So can we prove safety? We can't based on the incidents, but what we can do is look at surrogates of safety and whether or not we can wash out biochemical contaminants, whether we can remove cellular contaminants, and whether or not we can remove bacteria, which if you were querying anybody as to what they were afraid of in association with obstetrical hemorrhage, these would be the things the biochemical contaminants, at least with a washed cell salvage product. This study looked at whether or not tissue factors was active in a washed product and found that there was no tissue factor activity, which is shown in the far right column. And if you just increase the wash, you can increase the removal of any impurities in that blood. Particulate contaminants can be removed with these things. These are leukocyte depletion filters, which work through a microaggregate removal process, as well as an adhesion of cells. And this is a slide of blood that was collected from a cesarean section. You can see lots of junk. In the distant background, you can see faint blue dots, which are the red cells. And we did this study where we looked at washing its effect. And this is a higher power magnification where you see the red cells a little better. They are shown here in the background. And this is what happens when the filtration is applied. And so you have nothing but red cells, which are these blue circles. So this is one of the papers that I published where we looked at contamination of this blood across a number of different parameters and found that through washing and filtration, we could return a blood product that was equivalent to what was actually circulating in the mom. So on the far right is a post-wash, post-filtration, and in the first column under maternal is what was in the maternal circulation. We drew a blood sample with the point of placental separation and compared it. What about bacterial contaminants? We did further studies and looked at a number of different bacteria. We seeded blood, looked at the impact of washing and filtration, and found that we could remove anywhere from 97 to 100% of the bacterial contamination with the washing and filtration. So really, it seems like the blood that we can return, at least with a washing machine, is equivalent to what's in the mom. What's interesting is if you look at the blood from the blood bank, most specifically platelets in the United States, platelets are not refrigerated, so they grow bacteria if there is a source of bacteria. And this is a number of different bacteria that were identified by Rosalind Yamtovian in Cleveland, Ohio. You can see pretty high concentrations of bacteria were found in these platelets, that some of them were transfused and some of them weren't. But in general, the impact was negligible. Because of these findings, these organizations have recommended blood salvage as the option or the number one choice for managing hemorrhage during the course of obstetrical hemorrhage. And these are some pretty noteworthy organizations. Practical aspects. I'm going to skip through this because of time. Um, when we start thinking about using autotransfusion or cell salvage, again, it's when we use 20 swabs or laparotomy pads. That generally or identifies a bleeding case that's a little greater than normal. And this going back to the history, um, the collection of blood from these sponges was something that was commented upon by Harvey Cushing um, in in Boston, in Massachusetts General Hospital, back in 1925. In the course of bleeding that took place during intracranial operations, that they identified that the method of sponging could be used as an opportunity to collect blood. So this idea has been around for a long time. Um, so what we've implemented in our operating room is we take the lap sponges, as is shown here. A fully soaked lap sponge contains about 100 cc's of red cells. We rinse these sponges so that most of the red cells are removed and placed into a saline bath. And we can then suck this blood up into our autotransfusion system and it re-administered this blood. Um, and this is, again, getting back to that original observation of William Highmore, where they were, again, using unwashed blood to reinfuse into these women. And I wonder if this is an opportunity for countries like Nigeria, where you might not have access to the technology of an autotransfusion device, that would wash. This is a device that was invented by a former graduate student of mine at the University of Pittsburgh, um, Jillian Hanker, where this is just a giant syringe that she uses to suck up blood from a surgical hemorrhage. And the syringe is then used to basically push this blood back into the patient. Again, this is unwashed blood, and she's been trialing this in a number of countries, such as Ghana, and it seems to be life-saving. There's another device that could potentially be used in this circumstance. This is the ProCell automated sponge blood recovery device that squeezes the sponges, and you can collect blood out of the sponges. And I think these are opportunities that could be trialed in rural communities. So I heard in my introduction that checklists were being used or being recommended by an individual, and we've created checklists in our operating room in our labor suite, and this is one of those checklists. Um, and the checklists have basically grown iteratively over time. Um, as we have maternal adverse events, we add to our checklist. And this is just a memory tool to help people remember. And one of the things that we discovered many years ago was having adequate intravenous access was a problem in some of our women that were coming into our hospital from more rural locations when they're severely volume deplete or hypovolemic. It's very difficult to get IVs into them. So what we've done is we've adopted something called an intraosseous drill, which is super easy. This is a picture of an intraosseous drill, and you can put one of these into a patient in about 3 seconds. And it runs like a 16 gauge IV, and this can be pretty miraculous. I've given 3 units of red cells through one of these things, so it can be life-saving to have it rapidly um, access. Something that's becoming popular in the United States is aortic cross clamping, and not necessarily through opening the belly, but through using a device shown here. Um, this is a REBOA, a resuscitative endovascular balloon occlusion device. It's basically a Swan-Ganz catheter with a bigger balloon, and you float it up above the level of the uterine arteries, and you can stop blood flow um, to the uterus fairly rapidly through the use of this device while you're doing a hysterectomy, and it can be life-saving. Other things I think that are important, monitoring of laboratory data, and I don't know how accessible this particular laboratory data is, but for us in the United States, the thromboelastograph is a game changer in terms of strategizing our blood products. And the reason is that it gives us a functional fibrinogen, which is shown down here in the lower right-hand corner of the device, which tells us how much fibrinogen the patient has, and it helps us strategize whether or not we're going to give cryoprecipitate. Um, Transexamic acid is something that's become quite popular, but I'm not convinced that it has a huge role because fibrinolysis in obstetrical hemorrhage is something that doesn't happen, at least in my observation of many hemorrhaging women. It really doesn't happen in this patient population. It's more something that's a part of trauma. So, any rate, to give you some sense of what can be done, this is a case report of a woman that I took care of, where she came into our labor suite with a Duffy antibody, bleeding profusely from what ended up being a placenta accreta, and she bled down to hemoglobin of 1.5. And through the use of cell salvage, we were able to salvage 3 units of blood, retransfuse them into her, um, and we were able to get that 1.5 hemoglobin up to 5.3 while we did the hysterectomy.
No, no.
Hello. Yeah, I'm almost done. Give me 30 seconds. At any rate, this application of cell salvage was life-saving in this particular individual, and she went home on day 5 or day 4 of her postoperative course, having survived what would normally be considered a fatal anemia. So I will leave you there with a picture of our nursery. We have a football team in our town called the Steelers, and we indoctrinate our babies early on to rooting for the Steelers. So anyway, I will leave you with that. I think I hit the 35-minute mark on the dot, and I'd be happy to answer any questions. And I hope I've been relevant to the environments that you are practicing in. Great. Thank you for listening.
Thank you so much, Professor Jonathan Waters, for such a topic that is really very important to us in Nigeria, because obstetric hemorrhage is really something that tops our cause for maternal mortality rate. So in the last 30 minutes, Professor Waters has talked about perioperative blood management, patient blood management in obstetrics, um, the fact that our mortality rates are quite high, and hemorrhage tops it, and even in the US, hemorrhage ranks fourth at the cause of maternal mortality. So it's something that affects everybody, especially those of us anesthetists and especially obstetric anesthetists. He did talk a bit about the physiological changes in pregnancy as regards red blood cell mass and blood volume, the delays actually with maternal mortality, which is something that we get to experience. Um, Assessing blood loss using the QBL with the MOPS and the gauzes, the 1 gram to 1 mil, which we also do that. And the fact that blood availability is, I think, a worldwide issue. And I think there's still the scarcity of blood. So we're all looking at ways to, properly utilize blood. He gave a bit on historical basis of blood transfusion and auto transfusion and the current cell salvage equipment that are quite technical, that do a lot of washing and filtration. There have been a lot of controversies as regards cell salvage in cases where there's bacterial contamination, amniotic fluid, and all of that. And he, with the current equipment, who that do filtration and post-wash, they've been found that cell salvage can still occur in this group of women and without increasing risk of sepsis and embolism. He also talked about the use of the anesthesia hemorrhage checklist, which is a nice one. Checklist will help, will guide. And it's something that I think is we can always look towards. Of course, very important, the checklist was having wide bore cannula and access, and I think that is what we all tend to emphasize when we have obstetric patients, to ensure we have two IV access, wide bore IV access, and the use of intraosseous routes for blood transfusion. And of course, having the thromboelastograph machine also helps because it assesses the functionality of our platelets and it comes in very handy when you need to give coagulation factors. He's open for questions. He tried to keep to the time, but we have a lot of questions because obstetric is what we do really very, very commonly. And so we can ask our questions, we can drop them in the chat boxes. If you want to speak, if you put up your hands, then you would be asked to unmute and ask questions. Thank you.
Yeah, I tried to give some understanding of what you could do, and I don't think the maternal mortality rates that you guys face in Nigeria are astounding. And I think if you go back to historical development of transfusion medicine, there are lessons that can be learned to try to address that mortality. But it's a tough problem. Dr. Irene and I were talking earlier about possibly making a road trip to Nigeria. I'd love to try to understand this problem better because it's clearly a big one that you are facing. But anyway, I'd love to answer any questions that you might have.
Questions, please. Professor Waters, you don't seem to be pro use of tranexamic acid in suspected hemorrhage, or if you have ongoing hemorrhage in obstetrics.
Yeah, I mean, there's been a number of studies, that have demonstrated a very minor impact on mortality. And there's been some replication of Ian Roberts' study that was done in third world countries where there was a mortality advantage to using tranexamic acid, but in the first world, in the United States and Western Europe, that particular study was repeated and showed no impact of the tranexamic acid. So I'm not sure, if you're able to bring to bear all of the other tools for addressing this hemorrhage, that tranexamic acid has an impactful, eh, whether it's impactful in this particular environment. And again, I've followed a lot of thromboelastograph tracings in obstetrical hemorrhage, and I can't remember a single case where fibrinolysis was an issue, which is what you would be treating with tranexamic acid is fibrinolysis. So I think it's a relatively minor thing that you can do. I think there's better things that you can do, which is, again, to address anemia, get big IVs into people, um, and get blood products of some variety into them, regardless of what they are and where they come from. We've started using, or we've used unwashed salvage in a number of surgical environments for decades, and I think that it's worth revisiting, looking at unwashed salvage. So I'd be interested in hearing thoughts from others as to whether or not that's an opportunity.
Thank you. There's a question here from Dr. Isoka Ekpopo. She's an obstetrician. She says, thank you for the beautiful presentation. Which auto transfusion sets do we have available in Nigeria for ongoing PPH? I don't know, Dr. Kalua, President-elect, do we have, I don't know if we have any, we still use our methods that we use to do cell salvage. We don't wash, but we kind of filter them through blood, with some make-use filters. But I don't know if we have one. Maybe these
Yes,
big
we do.
hospitals will have some.
Yes, we do. Let me start from now and go backwards. Right now in our hospital and a few centers, Abuja and a few centers around the country, we are trying out HemoClear auto transfusion set, HemoClear. It works by gravity, and it actually filters the blood. We have used it, and then we reinfuse the blood. We did the control, and then we are currently in the intervention stage of the study, and then we are seeing how it's a demonstration study, so we'll see how to roll it out once the study is done. And for the older anesthetists are familiar with each set that was done by Professor Dr. Vaje. He was a military man, an anesthesiologist here in Nigeria. I'm surprised Jonathan didn't come across it. Maybe it wasn't well published, but I think I saw it in one or two literatures. And each set was one of those sets that was founded by our own Dr. Ovaje, a military anesthesiologist here in Nigeria. And of course, like you said, all of us who have practiced anesthesia long enough in Nigeria are familiar with the scoop and sieve technique, which we've been using. We never really studied it, but I mean, from the top of my head, long-term studies, since properly well-controlled studies were not done, we cannot say what the outcomes were. But at least immediate outcomes, we had, I don't ever remember any of my patients having issues. But maybe if we had some of those parameters that we were actually looking out for in a more controlled study setting, we would have been able to pick up one or two things. But those are our experiences with those. And splenectomies, ectopic pregnancies were very common with the scoop and sieve technique, and we had a lot of successes with them.
Yeah, I'd be interested in hearing about your application of the unwashed technology. In the United States, the devices that were sold for unwashed salvage typically limited the amount of blood that they would retransfuse to 1.5 liters of blood, which in obstetrical hemorrhage can be pretty common. And the reason for the limitations was DIC would occur when larger volumes of blood were reinfused. But it does point to the fact that we all have a certain amount of reserve to tolerate the contaminants in the unwashed blood. And, you know, tolerating those contaminants is better than dying. I have used the HemoClear. We did some quick and dirty studies with it, and the fundamental problem with it was just the speed with which the device filtered the blood. And then there's a limitation on how much blood you can put through the HemoClear filter. So it didn't seem, at least in the obstetrical environment, to offer much in terms of being life-saving. But I'm glad to hear that you're trialing it. That's really good.
Okay, first, this other question. Also, patient blood management obstetrics for what's your experience with Jehovah Witness patients who will not accept blood transfusion?
Well, that's a great
Have you
question.
tried to manage?
Yes. The Jehovah's Witness Church was founded in Pittsburgh, which some of you may know. So we have the largest population of Jehovah's Witnesses that come through our doors. We take care of about 1,600 women a year that are Jehovah's Witnesses. And so we have a pretty extensive experience. One of the things that I've discovered is that fatal anemia is not quite where we've historically defined it to be. Um, we have this idea that when somebody drops below a hemoglobin of 7, that they will drop dead. It just doesn't happen. I've taken care of 3 women who dropped below 2, and as long as you keep up with their blood volume, they're able to tolerate those low hemoglobin levels. And I'd be fascinated to hear, from you guys what your experience is as to how much anemia is actually tolerable, especially in pregnancy where women have built up remarkable reserve to tolerate anemia. But yeah, I have quite a bit of experience with the Jehovah's Witness population, and I think the cell salvage is something that 95% of our Jehovah's Witness patients will accept as long as it's their own blood. And I don't believe there's any church doctrine that specifies that the blood has to be kept in a continuous circuit, which is something that's become kind of mythology, at least in the American medical community, that you need to keep it in a continuous loop. But there is nothing in the church doctrine that requires for that to be the case. So, does anybody have any experiences with severe anemia where women have done well?
Dr. Kali, do you want to comment on that? Can you unmute, please?
Sorry, I saw Dr. Soro on the call.
Yes.
Dr. Soro is the president of the Bloodless Medicine and Surgery Society, and he is here in our hospital. I actually knew Jonathan Waters through him because Jonathan spoke in one of the Bloodless Medicine and Surgery events. And if Dr. Soro is still here, I would like him to speak because he's had some very interesting encounters with some patients with very low hemoglobin. But before he speaks, on my own, I want to say that I believe our patients are very resilient. I believe that Africans are very resilient because some of the things we see in literature do not really play out here. I'm commenting particularly about Jonathan's experiences with the speed and quantity of blood, I mean, using the HemoClear device. And I think that so far from what we have done, I think that it is going to make a very big difference in our practice if the preliminary results we are getting is anything to go by. Because once we keep the cardiac output of the patient normal, and we can put the patient's blood back within the patient, we are having very good results. In our environment, where sometimes between the cost barrier and other barriers to homologous blood transfusion, you find the patient in a situation where blood transfusion is not possible. And sometimes just for the mere fact of it, just keeping the cardiac output of the patient, pain control, infection control, and other things that can conserve oxygenation, we find out that the patients do well, not because of any special thing that we do. So we really need to rethink autologous, homologous blood transfusion. And I think that there is a lot of advantage in keeping the patient's own blood within the patient. But I'd like Dr. Usoro in just maybe 30 seconds to share one or two of those patients with some ridiculous hemoglobin that made it.
Yeah, thank you so much, Dr. Kalu. Can you hear me? Because I am in a rather noisy environment.
Very well, very well.
It's a children's day over here, and the children are all over the place having fun. So, yeah, thank you also. I'm so glad to be joining you. Dr. Kalu and myself are members of the Society for Advancement of Blood Management, as well as the Bloodless Medicine and Surgery Society. And Dr. Waters is a past president, as was mentioned, of that premier society for the advancement of blood management, as well as a member of the Bloodless Medicine and Surgery Society. So it's always a pleasure and a privilege to listen to him talking about blood salvage, which is his special area of interest and expertise. So as Dr. Kalu pointed out, we've been having pretty good success with the crude method of blood salvage. And even when we don't do the blood salvage, we've had patients with obstetric patients with hemoglobin drop to like 1.5 gram per dl. The anesthesiologists in Calabar, I have to say, they are really wonderful. They pushed in patients for surgery. I know of at least one case where patient's hemoglobin was 3.5. And it wasn't the surgeons pushing the patients in, it was the anesthesiologist for a hysterectomy for postpartum hemorrhage. And I don't know, like she said, off the top of my head, I cannot count any mortality where the bloodless surgery unit has been involved or requested to come in. So we know from experience that it's not really the hemoglobin that kills the patient, but there are a lot of associated factors that can kill, right from attempt to resuscitate with a lot of normal saline. So that can lead to circulatory overload, it can lead to acidosis, hypernatremia, hyperchloremia. All these are things that can kill the patient. A situation where a patient has some comorbidities, those comorbidities can also kill, like diabetes and so on and so forth. But if the problem is just low hemoglobin and we've solved everything else, we can raise it with IV iron and EPO in situations where the where either the clinician believes it's better off doing bloodless or the patient doesn't want a blood transfusion. So I think Dr. Kalu and myself will probably be more in favor of tranexamic acid being used in obstetric patients because of our own experience that we use them like in cesarean sections when we use tranexamic acid and maybe combined with vitamin K. It's dramatic. In fact, our surgeons, our obstetricians hardly will use diathermy. Once they use tranexamic acid and vitamin K. So I'll stop there and leave Dr. Kalu to fill us in on the rest.
Thank you very much. I've checked, I can't see more questions, but I think also probably raising up patients' blood levels, because anemia in pregnancy is something that can be addressed, and if that is properly managed, I think that would help. There's another question here, Professor Jonathan. Any experience with children? I know we're talking about obstetrics, so I don't know, do you do children?
I do children, and
Okay.
I do have experience, at least with our bloodless program, with managing children. They're particularly problematic in the United States, because our court system will basically force or mandate transfusion in children of Jehovah's Witnesses or who are Jehovah's Witnesses, and this becomes problematic. And I've had a lot of debates with pediatricians at our children's hospital about transfusing children that are anemic but are playing in the playground, where they don't need to be transfused. But the court will order transfusions against the wishes of the parents, and that's a particular problem that I think where we disrespect the wishes of the family. Um, but I think anything that you can apply to an adult, you can apply to a child. I mean, there's no reason that, things like erythropoietin and iron can't be utilized in the care of a pediatric patient.
Thank you. There's a question, is there any advantage with the use of carbetocin in reducing PPH? I don't know, what oxytocin are you familiar with or use regularly in your practice?
I'm sorry, utilization of what?
Carbetocin.
Oh,
Carbetocin in preventing PPH as an oxytocin, yes.
yeah, that's something we don't have available in the United States, so I don't really have any experience with it, but I'd certainly like to hear about it.
Okay. Which oxytocics do you routinely use?
Oh, we use oxytocin and hemabate or prostaglandin, and methogen, which is an ergot. Those are our um, tocolytic or um, are drugs that we use to contract the uterus.
Thank you. Okay, there's another question. I see patients with antepartum hemorrhage who come in with shock and need surgery. What would you advise?
Um, well, this is the circumstance, where we needed the interosseous drill, um, because we had a young woman that came in from a rural part of our state who was massively hypovolemic, and we couldn't get an IV into her, and the interosseous drill was something that we implemented in our armamentarium or in our toolbox following her death. Um, you can get an intraosseous drill in, I mean, in literally I mean, the minute you get the drill, you can have it placed in 1 second. And then you can connect it to an IV and start administering any kind of intravenous fluids. And those are the most important things, with anybody that's hypovolemic, is just get fluids into them. That's the most important thing. And then if you can get blood, um, all the better. But crystalloids or colloids, if you got it, give it.
Thank you very much. So I think we're done with the questions. The slides, I'm sure, will be shared on our YouTube, NSA YouTube pages, and
Yeah, I'll
also
send
I'll
them.
hand over. Okay. So I'll hand over to Dr. Queenette Kalu, who is the president-elect and the chair of the Education Committee, Nigerian Society of Anesthetists, to conclude the formalities. Thank you very much.
Thank you very much, Irene. Thank you very much, Jonathan. Very engaging session.
Thank you very much, sir.
So glad you could find the time. And I hope you didn't have to wake up too early to do this.
Oh, no.
Okay. So on the call today, I want to acknowledge Professor Antiabong. Professor Antiabong is a past registrar of the National Postgraduate Medical College of Nigeria. Thank you very much, Prof, for finding time to join us. I also want to acknowledge Professor Ilori. Professor Ilori is the, I think, immediate past or outgoing chairman of Faculty of Anesthesia, West African College of Surgeons. And I also want to acknowledge our chair robber, as we call it, faculty chairman of the Nigerians of the West African College of Surgeons, Faculty of Anesthesia, Professor Fakbonle. Thank you very much, ma'am, for finding time to join the call. I want to acknowledge Professor Edonwoyi. I want to acknowledge Dr. Ikene Omo. I have already acknowledged Dr. Nathaniel Usoro, who is it was through him I knew Jonathan. I thank you for finding time to join us. I acknowledge Dr. Komomo Iwara, an obstetrician gynecologist, and a whole lot of other people that I really don't know. Please, I'm very happy to have you here. Do we have anybody from one of our East African countries on the call? Can you say hello to us if you're here? Because I know our president usually shares the link, and sometimes we have one or two people. I can see Dr. Kalisto Senyuma, the consultant pediatrician in our institution. Thank you very much, sir, for finding time to join us. And a whole lot of other people. I want to thank you very much. We are very pleased that you could make it, and I believe that you learned a thing or two. One of the things I have learned from patient blood management, not just in obstetrics, but generally, is that it is best to keep the patient's blood within the patient. And especially in our environment where homologous blood transfusion is not available sometimes, and sometimes not affordable, and sometimes there are cost barriers between the patient and homologous blood transfusion. We need to learn how to maintain cardiac output and other blood conservative techniques. And like our moderator said, one of the low-hanging fruits in patient blood management is to make sure that the hematocrit of the patient is optimized. And our speaker elaborated a lot on that. So as much as possible, we have a lot that we can do nutritionally and otherwise. I'm happy that we have some obstetricians on the call who can optimize the hematocrit of the patient so that the allowable blood loss can be raised, and then we may not really need to transfuse the patient. So I also want to thank a lot of those who were working behind the scene, particularly resident doctors and representative, Dr. Afam. I want to acknowledge you all. And on that note, we want to call it a day for today. Thank you very much. Jonathan will be expecting the slides as promised. Thank you.
I will. Yeah, thank you.
Bye, everybody.
Bye-bye.